From the RSNA, I'm Dr. Jana Ivanice, and this is Radiology Imaging Cancer. We are back in your feed with a special podcast episode focused on an article recently published in our journal. Today's interview was conducted by our amazing trainee editorial board member, Dr. Vishnu Chandra. Vishnu is a radiology and interventional radiology resident at the University of Virginia. He interviewed Dr. Julius Chapiro, who, as you will hear, is an incredibly accomplished interventional radiologist, physician scientist, and mentor, among many other roles, at Yale School of Medicine, where he heads the Interventional Oncology Research Lab, again among many other accomplishments. Drs. Chandra and Shapiro will discuss a paper published in Radiology Imaging Cancer in 2022 by Dr. Shapiro's team, which is titled Optimization of the BCLC Staging System for Locoregional Therapy for Hepatocellular Carcinoma by using Quantitative Tumor Burden Imaging Biomarkers at MRI. I hope you enjoy this podcast episode, and as always, we look forward to your feedback.
Hi, everyone. My name is Vishnu Chandra. I'm a third-year radiology and interventional radiology resident at the University of Virginia and a member of the Trainee editorial board for Radiology Imaging Cancer. I have here with me Dr. Julius Chapiro, who is the senior and corresponding author of a manuscript published in 2022 in Radiology titled Optimization of the BCLC Staging System for Locoregional Therapy for Hepatocellular Carcinoma using quantitative tumor burden imaging biomarkers at MRI. Dr. Chapiro is currently an assistant professor in radiology, hepatology, and the biomedical engineering departments, as well as the principal investigator of the highly productive Yale Interventional Oncology Research Lab. He's also the associate director of the clinical and translational core of the Yale Liver Center. Dr. Shapiro's research focuses on developing new quantitative imaging biomarkers for the diagnosis, characterization, and therapeutic management of liver cancer. And he also has extensive background in basic research, and his interest mainly focuses on developing new tools to characterize the tumor microenvironment and the immune system in setting of local, regional, and image-guided therapies. And he uses several different animal models to that end. So, Dr. Chapiro, it is great to have you on this radiology podcast series. Thank you for being here today.
Thank you, Dr. Chandra. Great to be here.
So, your article was published last year, and it was very interesting to me because when I talked to trainees from various institutions, there is a lot of variability in patient selection for different local regional therapies, especially when it comes to selecting patients for TACE or conventional TACE or even DEB TACE. So I know you've published several papers on specifically tumor biomarkers of various cancers, including colorectal metastases to the liver, neuroendocrine tumors. So could you please talk about what inspired this particular study and kind of briefly summarize the findings?
Well, thank you for the introduction. So the study was conceived about the year 2000, and back then the BCLC staging system was not yet updated. The most recent update came through in the year 2022, and it is just has been endorsed by the European Association for the Study of the Liver. And that new update reflects some of the suggestions that we published, but also just quite naturally address some of the issues we try to focus on in this paper. And the original idea to publish this paper was focusing on the intermediate stage of HCC, which is a pretty broad group of patients that gets diagnosed relatively unresectable stages for the majority of these patients. Some patients can be downstage towards transplantation, and that is reflected in the new BCLC update, but the majority of patients is no longer within the realm of surgical candidacy. And so we wanted to identify biomarkers that help us select patients in that group for locoregional therapy, but also look for patients who might not be good candidates. And to the same token, we wanted to also look at patients in advanced stages in BCLC-C who might formerly been grouped into advanced stage, either due to a high ECOG score or very subsegmental portal vein thrombus, but still might have been good candidates for locoregional therapy. And while formally the BCLC staging system selects those patients for systemic therapy, in practice, we know that these patients sometimes may benefit from locoregional, or at least the addition of locoregional. And in light of so many trials that have been designed to compare in combination with immunotherapy with TACE alone, we just wanted to know what is the ideal allocation mechanism. And the second thought behind the paper was to really look at imaging as a really surrogate marker at baseline for what the patient's outcome is going to be. And note that most staging systems, and that goes beyond BCLC, simply measure direct tumor diameter as an indicator for how to stage a patient. And we've learned in our journeys through understanding tumor response in HCC that simple tumor diameter measured as RECIST response is not always appropriate in HCC. And so there we understood very early that mRECIST, which measures the enhancing portion of the tumor just in a caliper-based fashion in a unidirectional measurement, that is much more sensitive. So we thought that introducing viable tumor volume into the equation and understanding in a volumetric fashion how big a tumor is and how viable a tumor is might be a pretty good starting point to assign a patient to a therapy, whether this is a systemic therapy or whether this is locoregional therapy. And the paper does just that.
That there were the two major biomarkers that we were specifically looking at in this study was estimated tumor burden and estimated tumor volume. As far as, the results showed that BCLC C patients with low viable tumor burden did have a significant survival benefit when treated with TACE when compared to those BCLC patients that had a higher viable tumor burden. So I guess the results of this study, did that also kind of confirm your suspicions? And did you already kind of intuitively know this? And was your practice pattern already changing, or have your practice patterns changed since then?
Well, basically, this study, because it is a retrospective analysis of about close to 500 patients, mostly from the time at Johns Hopkins and also mixed in with some data from Yale, this has been a clinical practice. And I want to say one thing about the BCLC staging system. The Bridge study, which was published a couple of years ago, really looked at the utilization of the BCLC staging system as truly the reflection of clinical reality. And we know both from clinical practice as well as from just reported reality that the BCLC staging system is not much more than a recommendation, and over 40 to 45% of the patients globally are treated off guideline. And that really reflects the fact that the clinical reality is much more confusing and much more complex than the original BCLC staging system actually allowed. And you will see that in the 2022 update of the BCLC staging system, that intermixed reality on the lower portions of the staging system is actually reflected, because there is really a possibility for every stage to migrate in terms of the therapeutic recommendation. And that is really a key fact. And I think that the new 2022 BCLC stage system favors the late BCLC-B to be treated with systemic therapy, but in reality, there is a lot of clinical trials that still combine locoregional and systemic in those patients and BCLC-C patients. And we knew that TACE in particular is very effective at knocking out a small amount of residual viable tumor, obviously in case the vasculature is still patent and the patient is sometimes therapy naive. And we also, as you mentioned, we introduced two markers. There is the enhancing tumor volume, which is an absolute marker in cubic centimeters and really reflects how much viable tumor volume there is in cubic centimeters, but also the viable tumor burden. And that introduces the residual remnant liver function a little bit. And so even if though you might have a large absolute numeric number of viable tumor, if the liver overall is large and there is a good liver function in the underlying parenchyma, then the viable tumor burden, which is the relationship between the tumor and their total liver volume, can still be low. And so these patients still benefit from locoregional therapy, even if you end up having a somewhat non-target embolization of, for example, a large segment or even multiple segments. So that is very important for us to really just take the simple measurement of a diameter out of a conversation and just try to see the liver as a whole.
And just to kind of follow up on that, as a trainee, I haven't really seen the estimated tumor volume and estimated tumor burden like prospectively when we're evaluating these patients before a case. Are there situations when these two biomarkers are discordant where, like you kind of pointed out, that you may have a high estimated tumor volume, but if the burden is lower and they have a large liver volume, you may still be more aggressive in treating them. So is there one you rely on?
So first of all, the daily clinical utilization of measuring both tumor volume as well as the lobar liver volume is obviously Y90 dosimetry. And, thanks to the visionary leadership of Riyad Salem and Y90, I think that we have now come to acquaint ourselves and really be comfortable with measuring those things and introducing them to locoregional therapy. I don't think we're actually doing a really good job in TACE at looking at those things just because we don't have to calculate the dose. And I think that's really to the detriment of our outcomes in part. What I would say is that we definitely should, in many institutions, we do measure the relationship between the residual liver and the tumor volume. And another therapy that we actually do regularly in interventional radiology also utilizes these functions. And I'm sure you've heard about portal vein embolization in patients where we're trying to hypertrophy the unaffected liver lobe prior to resecting the affected lobe, mostly for colorectal liver mets or other mets in the liver, sometimes even more rarely in HCC. But overall, the principle here behind it in this therapy is that you want to calculate the future liver remnant after you deliver a pretty significant cytoreductive dose to the tumor and potentially to half of the liver. Or if you are trying to resect part of the liver, an extended hepatectomy or in a trisectorectomy, basically, we're using those volumes regularly. I think that from my perspective, if I would have to choose between the two, I would try to answer different questions. So if you're looking at the enhancing tumor volume, that is something that you need to know because probably the dose that you can deliver will be slightly dependent on the amount of enhancing tumor volume. Because obviously, if there is non enhancing or necrotic liver, that's not going to be perfused and you're not going to be able to deliver anything through the artery. But if you're looking at the enhancing tumor burden, that gives you sort of a prospect on how well will this patient fare if you treat pretty aggressively, even larger tumors, and how much hepatic reserve will this patient have in terms of liver function. And I think when you treat liver cancer, particularly in cirrhotic patients and primary liver cancer, with compromised and liver function, you always have to think about the residual liver. And I like how the portal vein embolizationists are thinking about it in terms of future liver remnant. I think we need to think in those dimensions more when we apply TACE as well.
Very, very interesting. One other kind of question I had about kind of stratification of the BCLC-B and BCLC-C patients. So you found that among BCLC-B patients, those that did have a enhancing tumor volume lower than 65 actually had a median of overall survival of 33 months compared to 21 months for those. So focus of the study ended up being on BCLC-C patients because those are the patients that are sometimes getting excluded from treatment, from TACE, because of guidelines. But does that have implications for you for the BCLC-B patients and kind of follow up, whether you may treat them more aggressively?
Well, I mean, first of all, these numbers really, I mean, particularly the number less than 65 cubic centimeters, those are sort of like your standard, like the middle part of the BCLCB staging system. Those tumors and those patients do very well. And the number of 32.9 months of median survival in this group, that really demonstrates just a new standard of care that we should aim for. Because remember that the systemic therapies have made great progress. I mean, we started off with sorafenib with the median overall survival, depending on the trial, somewhere between 12 and 16 months, and now atezo and bev, the combination, really in BCLCC is punching close to 22, 24 months by now, right? And this is BCLCC. So at the same time, the median overall survival of patients with BCLCB treated with TACE went within less than a decade, went from on average published 23, 25 months to now 30 to 35. And all that shows is really that in our cohort or in our institution, our analysis, these patients actually did really, really well. Because if your average BCLCB patient lives 32, 33 months, that means you're doing something right. And that is certainly the result of novel catheter technology, such as like our ability to advance microcatheters super selectively into the tumor and then treat these patients multiple times if they need to be. From just a practice perspective, I think that if you're treating larger BCLCB, you clearly see that the survival is lower. Also, probably because you will be able to achieve lower overall complete response rate after the first therapy. And I think that really is reflected in the lower overall survival rate. But even there, we punch still well within range. So I think at this point, we will be very soon challenged to introduce systemic immunotherapies even in BCLCB as a combination to locoregional therapy, under no circumstances a replacement. And I do think that this biomarker, a cutoff of 65 cubic centimeters in BCLCB, might be a really good selection factor of combining probably the ones that don't do that well, so have more than 65 cubic centimeters of viable tumor and are still BCLCB, would be better candidates to combine with systemic therapies, systemic immunotherapies followed by TACE or TACE and then immunotherapy, rather than patients who really do really well with 33 months on their own just with locoregional.
That makes sense. That was actually going to be kind of one of my follow-up questions is what do you think are some future directions of kind of that are stemming off this particular project?
Well, I mean, we're working on a variety of biomarkers, and I do think that quantitative assessment of viable tumor is certainly one of them. I think that at this point, we are trying and are actively in the process of applying the same technology, assessing quantitative enhancing tumor burden and tumor volume in the setting of systemic immunotherapies. I mean, we have a pretty good site experience here at Yale. We have close to 100 patients that had immunotherapy in MR imaging, both at baseline and at follow-up. And right now we're looking into applying these very same cutoffs and trying to understand which patients can be initially predicted to fail immunotherapy and which patients can actually be predicted to succeed. I think that these biomarkers are pretty specific in that they provide you with a picture of growth potential, but they're not omnipotent. So we're going to have to combine them with probably some clinical information and build more composite clinical predictors. And BCLCB is still work in progress, mostly even with the novel staging system update in 2022. So I think that we will be able to build clinical trials based on true tumor viability data and tumor kinetics. And this will help us really build better trials and tease out cohorts where combination therapies are helpful. And it's a work in progress.
That sounds very, very interesting. And I am looking forward to reading some of your future work. Dr. Chapiro, I know I could talk for much longer on so many different things you've published, including some of the animal models that you're working on, but I don't want to take up too much of your time. So thank you so much. It was a pleasure talking with you.
Absolutely. Thank you for interviewing me.
This concludes today's episode. Many thanks to Vishnu and Julius for this fascinating and engaging discussion. I look forward to continuing following Dr. Shapiro's work in the future. Thank you all for listening, and we look forward to your feedback via email or on Twitter. I'm Dr. Jana Ivanice, and this is Radiology Imaging Cancer.